Hi, good evening, everyone. Tejasvi, can we start?
Yeah, Meghana, you can start now.
Yeah. A very good evening, everyone. I welcome you all to the day two of our therapeutic presentations. Today's our main topic and focus is on the pharmacology and drug profile related to myocardial infarction. Before we start the presentation, let's quickly go through the uh, rules and regulations. Rules and regulations for drug profile and pharmacology, as we have already shared, the drug profile will be in this format of the drug profile, presentation, name of the drug, history, brand names, indications, side effects, drug interactions, pharmacology, pharmacokinetics. If any dose modifications are there, that can also be included. Warnings and precautions, contraindications, pregnancy and lactation, all this will be included in the drug profile of pharmacology. After the presentation, the presenter can also present the additional information such as like off-the-label use and also any patient material related education and all. Everything the presenter can present. First 20 minutes, the presenter will be presenting the presentation, and after that 10 minutes Q&A session will be there. Once the presenter completes with our 15 minutes of presentation, 5 minutes will be before 5 minutes, the buzzer will be given by our team, and in the next 5 minutes she can complete the presentation. Before we begin, I'm very curious to ask you all a question actually. How many of you have this love-hate relationship with this pharmacology? I just want to know out of curiosity, because as pharmd, all the pharmacy graduates should be well strong and solid knowledge on the pharmacology. So to show our unique expertise in this field, we have to have the understanding on the pharmacology. So let's dive into the session. Without further delay, let me call upon Nandhini. I hope Nandhini is here. Nandhini, are you here?
Hello, am I audible?
Yeah. I welcome Nandhini, who will be presenting on the pharmacology of MI. I'll be sharing the screen now. You can start your presentation, Nandhini.
Okay.
Can you please confirm me whether it is visible?
Yes, it is. Shall I
Okay, you can
start?
start the presentation.
Okay. Good afternoon, good evening, everyone. I am Nandhini, Annamalai University from Tamil Nadu. I'm here to present the topic Pharmacology of the drugs used in myocardial infarction. Can you please change the slide? As we all saw what is myocardial infarction in previous classes, it is a short review here. Myocardial infarction is a ischemic necrosis of a portion of a myocardium, a cardiac muscle, due to sudden occlusion of a branch of coronary artery. ECG, biomarkers, hemodynamic parameters are used to guide selection of drugs and dosage. Myocardial infarction can be classified into three types: unstable angina, NSTEMI, and STEMI. Unstable angina, ST segment in ECG is not elevated and biochemical parameters are not increased. In STEMI, ST segment is not elevated and biochemical parameters are increased. STEMI, ST segment elevated and biochemical parameters are increased. Next slide, please. Drug therapy in MI. Following is a procedure or a protocol to be followed when a patient is presented with myocardial infarction. Number one is oxygenation. When the saturation of a patient is low, oxygen can be provided if required. Nitroglycerin is a first line treatment for myocardial infarction. Next is pain management. Following 3 doses of nitroglycerin, if the chest pain of the patient is not reduced, opioid analgesics like morphine can be administered parenterally to reduce the chest pain. Maintenance of blood volume, tissue perfusion, and microcirculation. In order to maintain the blood volume, tissue perfusion, and microcirculation, saline or dextrose can be used as a slow intravenous infusions. Also, that overload should be avoided. Next is correction of acidosis. In MI patients, most patients experience acidosis due to lactic acid production. So, in order to reduce that, IV sodium bicarbonate infusion is done. Next is prevention and treatment of arrhythmias. In order to prevent arrhythmias, beta blockers along with ACE inhibitors can be used in case of no contraindications. Next is pump failure. Pump failure occurs when the cardiac output is reduced. In order to increase the cardiac output, diuretics like furosemide, vasodilators such as uh, nitroglycerin, esmolol, or labetalol can be used. Also, ionotropic agents like dopamine, dobutamine can be used. Next is prevention of thrombus extension, embolism, and thrombus embolism. For this purpose, antiplatelet and anticoagulants are used. Next is prevention of future attacks. In order to prevent future attacks, a patient must be advised with platelet inhibitors, beta blockers, and controlling hyperlipidemia via statins. Next slide, please. Okay, the first drug is nitroglycerin. Nitroglycerin was first synthesized in 1847 by Ascania Sorbero. Brand names include Nitrostat, Nitrobid, Nitrodur, Minitran, Nitrolingual, etc. It is indicated in case of angina pectoris, heart failure, and acute myocardial infarction. The common side effects include headache, hypotension, dizziness, flushing. It interacts with phosphodiesterase inhibitors, alcohol, and calcium channel blockers. Pharmacology is a vasodilator. The nitroglycerin binds with sulfhydryl groups of cells, thereby increasing endothelial factors such as nitrogen oxide, which in turn produces calcium ions, therefore producing vasodilation and reducing cardiac workload. Next slide, please. Pharmacokinetics. The drug is rapidly absorbed. It has wide distribution, metabolized in liver, excreted in kidney and feces. Available dosage forms include sublingual tablets, oral tablets, transdermal patches. Dose strength 0.3 mg, 0.5 mg, 5 mg, 10 mg, and 20 mg. Dose modification. The required dose is adjusted based on response and condition of a patient. Warning or precaution. Uh, it is cautiously used in patients with hypertension, and it has an ability to develop tolerance and rebound angina. Pregnancy category is C. Lactation and lactation details are not available. Black box warnings: severe hypertension with concurrent use of phosphodiesterase inhibitors. Contraindication: hypersensitivity to nitroglycerin, severe anemia, increased intracranial pressure, severe hypertension, concomitant use with phosphodiesterase inhibitors like sildenafil, tadalafil, and vardenafil. Next slide, please. Next is antiplatelet agents. As we all know, these agents are also called as antithrombotic agents. These agents interfere with platelet function and used in prophylaxis of thromboembolic disorders. The most commonly used drug includes aspirin, clopidogrel, and ticagrelor. Aspirin is a thromboxane synthesis inhibitor. It has been used for centuries and first synthesized in pure form in 1987 by Felix Hoffmann at Bayer. Brand names include aspirin, ecotrin, bufferin, ecosporin. It is indicated in case of ischemic heart diseases, atrial fibrillation, cerebrovascular diseases, pulmonary hypertension. Side effects include gastrointestinal irritation or bleeding, allergic reaction, tinnitus, exacerbation of asthma. Interaction with warfarin, other anticoagulants, antiplatelet drugs, NSAIDs, alcohol, and several herbal supplements. Next slide, please. Pharmacology of aspirin. It inhibits cyclooxygenase and thereby reduces prostaglandins or thromboxane production. Pharmacokinetics. Rapidly absorbed. It has wide distribution and crosses blood-brain barrier. It is metabolized in liver by cytochrome P2C19 isoenzymes, excreted in kidney and feces. Dosage forms available include tablets, chewable tablets, entry-coated tablets, and suppositories. Available dose strength 75 mg, 325 mg, 1 gram. Next slide, please. Dose modification. Dose modifications required in renal or hepatic impairment and in patients with bleeding risk. Warning or precaution. Caution in ulcers, bleeding disorders, asthma, allergies. Monitor for adverse effects with prolonged use. Pregnancy category. It is not used. It is not advised in third trimester. Lactation. It is excreted, but low dose can be used. Black box warnings. Bleeding. Contraindication, hypersensitivity, active bleeding, severe kidney or liver disease, Reye syndrome. Can you please go back to last second slide? First slide of antiplatelet agents. Oh, thank you. Next is a clopidogrel. It is a P2Y12 receptor blocker. It is first introduced in 1997. Brand names include Plavix, Clopilate. It is indicated like aspirin, ischemic heart diseases, atrial fibrillation, cerebrovascular diseases, pulmonary hypertension. Side effects include bleeding, rash, itching, diarrhea, stomach pain, headache, etc. Interaction interacts with other anticoagulants, NSAIDs, proton pump inhibitors, and certain antidepressants. Next slide, please. It inhibits platelet aggregation. This one. It irreversibly blocks P2Y12 receptors in platelet surface. It is rapidly absorbed. Protein binding is 98%. Metabolized in liver by cytochrome P2C19 isoenzymes. Excreted via kidney and feces. Available dosage form oral tablets. Available dose strength 75 mg, 300 mg. Next slide, please. Dosage adjustment may be required in patients with certain genetic variations. Warning or precaution. Risk of bleeding. Avoid in patients with active bleeding or ulcer. The pregnancy category is B. Lactation. Caution while usage. It can be used but must be cautious while using. No black box warnings. Contraindicated in patients with active pathological bleeding, hypersensitivity to clopidogrel or any other component of the tablet. Can you go back to the last second slide? Ticagrelor is a latest antiplatelet agent introduced in 2011. Brand names include Brilinta. Indication is like other antiplatelet agents. Side effects include bleeding, shortness of breath, headache, dizziness, and nausea. It interacts with cytochrome P3A4 inhibitors, aspirin, anticoagulants, and certain antidepressants. Next slide, please. No, the before one. Pharmacology of ticagrelor, reversible P2Y12 receptor antagonist. This is the main difference between clopidogrel and ticagrelor. Pharmacokinetics include rapid absorption, protein binding 99%, liver metabolized by cytochrome P3A4 enzymes, excreted via kidney and feces. Available dosage form oral tablets, dosage strength 60 mg and 90 mg. Next slide, please. Dose modification is not required for ticagrelor. Warning or precaution, risk of bleeding, avoid in patients with active bleeding or intracranial hemorrhage. Pregnancy category B, like clopidogrel in lactating mothers, it must be used cautiously. Black box warnings include nothing. Contraindications, active pathological bleeding, hypersensitivity to ticagrelor, history of intracranial hemorrhage. Next slide, please. Next is anticoagulants. Anticoagulants are used to reduce coagulability of the blood. It can be classified into two based on route of dosage. One is IV and oral. IV forms include heparin, LMWH, fondaparinux, and bilaviridin. Here only oral anticoagulants like warfarin, apixaban, rivaroxaban are introduced. IV anticoagulants can be used only in emergency departments and not very much required during next 3 to 4 days after the MI attacks. First drug is warfarin. It was first introduced in 1948. Brand names include Coumadin, Jantoven, Meraven, Varin, and others. Indication: Anticoagulant therapy for various conditions, including thromboembolic disorders. Side effects on the bleeding include gastrointestinal bleeding. Next slide, please. Pharmacology of warfarin. It inhibits vitamin K epoxide reductase enzyme, thereby reducing vitamin K dependent clotting factors. Pharmacokinetics, well absorbed orally. It has wide distribution, metabolized by liver, cytochrome P9 isoenzymes, excretion via kidney and feces. Available dosage forms is tablets, oral solution, injectable formulations. Dose strength 5 mg. Next slide, please. Dose modification. It is individualized based on INR, that is international normalized ratio, monitoring and patient response. The INR must be between 2.5 and 3.5. A warning or precaution: bleeding risk. Pregnancy category X, contraindicated in patients with known hypersensitivity to warfarin, active bleeding, and liver disease. Can you go back to the last second slide? Thank you. Apixaban. Apixaban is another oral anticoagulant approved for medical use in 2012. Brand names include Eliquis. It is indicated for atrial fibrillation, deep vein thrombosis, pulmonary embolism, and prevention of stroke. Side effects include bleeding, gastrointestinal bleeding, bruising, elevated liver enzymes, rashes, and anemia. Next slide, please. Pharmacology. It is a direct factor 10A inhibitor, thereby preventing formation of thrombin and coagulation. Pharmacokinetics, rapid absorption, highly bound to protein, that is plasma proteins, metabolized in liver by cytochrome P3A4 enzymes, excreted in kidney and feces. Available dosage form, tablets in dose strength 2.5 mg, 5 mg, and 10 mg. Next slide, please. Dose modification is required and is adjusted based on renal function and other factors. Warning or precaution: bleeding risk, renal and hepatic impairment, risk of thromboembolic events. Pregnancy category B, contraindication, known hypersensitivity to apixaban, active bleeding, and liver disease. Can you go back to the last second slide? Rivaroxaban. No, next one. Thank you. Rivaroxaban, it is another anticoagulant approved for medical use in 2001. Available in brand names Xarelto. It is indicated for atrial fibrillation, deep vein thrombosis, pulmonary embolism, and prevention of stroke. Side effects include bleeding, gastrointestinal bleeding, bruising, elevated liver enzymes, rashes, and anemia. Next slide, please. Pharmacology. It is pharmacology of rivaroxaban. It is also a direct factor 10A inhibitor, thereby preventing formation of thrombin. Pharmacokinetics include rapid absorption, highly bound to proteins. It is metabolized in liver by two enzymes, cytochrome P3A4 and cytochrome P2J2. It is excreted in kidney and feces. Dosage form include tablets. Dose strength available is 2.5 mg, 10 mg, 15 mg, and 20 mg. Next slide, please. Rivaroxaban is adjusted. Dose of rivaroxaban is adjusted based on renal function and other factors. Warning or precaution: bleeding risk, renal and hepatic impairment, risk of any thromboembolic events. Pregnancy category C, contraindication, known hypersensitivity to rivaroxaban, active bleeding, and liver disease. Next slide, please. Fibrinolytics. Fibrinolytics are the agents that are used to lyse a thrombi or a clot and recanalize the occluded blood vessels. It is most commonly used in STEMI, that is ST elevated myocardial infarction. The common drugs include streptokinase, alteplase, and tenelactapase. Streptokinase is the first fibrinolytic used. and discovered in 1940, but came to usage in 1950s. It is obtained from a microorganism, Beta streptococci. Later, many effective and fibrinolytics have been developed. Brand names include Cabekinase, streptase. It is indicated for acute myocardial infarction, pulmonary embolism. Side effects include bleeding, allergic reactions. Next slide, please. Pharmacology, it binds and activates plasminogen. Plasminogen is a factor that converts into plasmin, which in turn converts insoluble fibrins into soluble fibrins, thereby recanalizing the occluded blood vessels. Pharmacokinetics include absorbed via intravenous administration. It has a wide distribution, metabolized in liver and excreted via kidneys. Dosage forms available is powder for reconstitution. Dosage strength 250,000 international units and 750,000 international units. Next slide, please. Dose modification, it is adjusted based on patient weight and condition. Warning or precaution, serious bleeding risk, pregnancy category C. Black box warnings is also serious bleeding risk, contraindicated, active internal bleeding, recent surgery, severe hypertension. Can you go back to last second slide? Thank you. Next is Altiplase. It is developed in 1980s. Brand names include Activase, Actilase. Indication acute ischemic stroke and myocardial infarction. Side effects are same as streptokinase like bleeding and allergic reactions. Next slide, please. Pharmacology, it converts plasminogen into plasmin. Pharmacokinetics, absorption via intravenous administration. It has a wide distribution, metabolized through liver and kidney, metabolized through liver and excreted through kidney. Dosage available for reconstitution. Dose strength available 50 mg and 100 mg. Next slide, please. Dose modification adjusted based on patient weight and condition. Warning or precaution, serious bleeding risk, pregnancy category C. Black box warning, serious bleeding risk, contraindication, active internal bleeding, recent surgery, severe hypertension. Can you go back to the last second slide? Next is Tenectil Place. It is developed in 1990s. Brand names include TNKs, indicated in acute myocardial infarction. Side effects include bleeding and allergic reactions. Next slide, please. Pharmacology, this also converts plasminogen into plasmin. Pharmacokinetics, absorption via IV administration. It has a wide distribution, metabolized through liver and excreted through kidneys. Available dosage form is a powder for reconstitution. Dose strength 50 mg. Next slide, please. Dose modification is adjusted based on patient weight and condition. Warning or precaution, serious bleeding risk, pregnancy category C. Black box warning, serious bleeding risk. Contraindication, active internal bleeding, recent surgery, and severe hypertension. Next slide, please. Next is beta blockers. Beta blockers used for myocardial infarction are cardioselective. They are used to prevent sudden cardiac arrest along with AC inhibitors in order to reduce cardiac workload. It is most routinely used in unstable angina and in STEMI. Beta blockers reduce myocardial oxygen demand and thereby reducing the risk of impending MI or sudden cardiac death. There are two main reasons why beta blockers has been used for MI. First is secondary prevention of a future attack. Long-term use after recovery from MI has reduced the mortality by 20% by preventing reinfarction and sudden ventricular fibrillation. Another is myocardial salvage during evolution of MI. While administering beta blockers within 4 to 6 hours of MI attack, followed by oral therapy, this might limit the infarct size and prevent sudden ventricular fibrillation. Commonly used beta blockers include metoprolol, cardiolol, and atenolol. Metoprolol was first introduced in 1975. Brand names include low pressure, Tropol XL, and many others. Indication hypertension, angina pectoris, heart failure, myocardial infarction, and atrial fibrillation. Side effects include fatigue, dizziness, hypertension, in rare cases, depression. Interaction with other antihypertensive, antiarrhythmics, and NSAIDs. Next slide, please. Pharmacology, it is a selective beta 1 adrenergic receptor blocker. Pharmacokinetics include rapid absorption, wide distribution, crosses blood brain barrier, metabolized in liver by cytochrome P2D6 enzymes, excreted through kidneys. The available dosage forms tablets, extended release tablets, and oral solution. Available dose strength 25 mg, 50 mg, 100 mg, and 200 mg. Next slide, please. Hello. Next slide, please. A dose modification is not required for any type of beta blockers. Warning or precaution. Abrupt withdrawal may exacerbate angina or precipitate MI. Use with caution in patients with heart failure, bradycardia, or hypertension. Pregnancy category C. Contraindication. Known hypersensitivity to metoprolol, severe bradycardia, cardiogenic shock, heart block greater than first degree. Can you please go back to the last second slide? Next is Cardivalol, approved for medical use in 1995. Brand names include Correct and Correct CR. Indication hypertension, heart failure, left ventricular dystrophy following myocardial infarction. Side effects include fatigue, dizziness, hypertension, bradycardia, and diarrhea. Interaction interacts with other antihypertensives, antiarrhythmics, and NSAIDs. Next slide, please. It is a non-selective beta adrenergic blocker and alpha 1 adrenergic receptor blocker. Pharmacokinetics include rapid absorption, wide distribution, crosses blood-brain barrier. It is metabolized in liver by two enzymes, cytochrome P2D6 and cytochrome P2C9, excreted via kidney and feces. Dosage forms include tablets and extended release tablets. Dose strength available are 3.125 mg, 6.25 mg, 12.5 mg, and 25 mg. Next slide, please. As I said earlier, dose modification is not required. Warning or precaution is same as metoprolol. Abrupt withdrawal may exacerbate angina or precipitate myocardial infarction. Use with caution in patients with heart failure, bradycardia, or hypertension. Pregnancy category C. Contraindication, known hypersensitivity to carvedilol, severe bradycardia, cardiogenic shock, heart block greater than first degree. Can you go back to the last second slide? Next drug is atenolol. It was first introduced in 1976. Brand names available: Ternormin. Indication hypertension, angina pectoris, and acute myocardial infarction. Side effects include fatigue, dizziness, hypertension, bradycardia, and cold extremities. Interacts with other antihypertensives, antiarrhythmics, and NSAIDs. Next slide, please. Pharmacology. It is a selective beta 1 adrenergic receptor blocker. Pharmacokinetics, rapid absorption, crosses placenta and enters breast milk. Metabolism, minimal hepatic metabolism, excreted via kidneys. Dosage forms available is only tablets. Dose strength 25 mg, 50 mg, and 100 mg. Next slide, please. Dose modification is not required. Warning or precaution: abrupt withdrawal may exacerbate angina, precipitate MI. Use with caution in patients with heart failure, bradycardia, hypertension. Pregnancy category C. Contraindications: known hypersensitivity, sinus bradycardia, cardiogenic shock, heart block greater than first degree. Thank you.
Thank you so much, Nandini. It was really insightful presentation by you. You have covered all the drugs of myocardial infarction in detail. So let's now move on to the Q&A session. Guys, if you have any doubts or any questions to the presenter, you can please post it in the chat box so that I'll be asking to. Any questions to the presenter, you can please post it in the chat box. Yeah, you can unmute yourself and also ask the presenter directly. I found a question here. Can anyone tell what is the nitrate-free interval? What is nitrate-free interval? Nandhini, if you can answer. Okay, the next question here. Can you please explain the mechanism how aspirin exacerbate asthma? Nandhini, are you here? You can
Yes, I
unmute
am.
yourself.
Yes, I am here, but I don't know how it exacerbates. I just have an explanation. It exacerbates. I couldn't find the answer myself too.
Okay. Why beta blockers are not recommended in treatment of STEMI?
Sorry, I don't know. It is
If,
most common. It is not like you should not be using for STEMI. It can be used in case of increased blood pressure. It is most routine. It is a part of a drug regimen for unstable angina and STEMI.
how can aspirin increase exacerbation of asthma? If anyone can answer this question, please unmute yourself and ask and reply. The
I
next
guess
question.
aspirin and I exacerbates the chemical mediators of inflammation in asthma. Exactly don't know the mechanism, but I guess that's the reason. COX may be involved.
Yeah. The next question. Altiplase and tenecteplase have same mechanism of action, but which one is more safe to use in MI patients?
It is tenecteplase as it has a lower incidence of side effects and ADR occurrence. It is the latest found drug, so tenecteplase is the most safe.
Yeah. Any more questions?
Can I answer a query from the chat box?
Yeah, you can answer, Sadhya.
About the asthma? I guess aspirin inhibits the cyclooxygenase enzyme. So, which is responsible for production of chemical called prostaglandins. So, inhibition of cyclooxygenase leads to accumulation of leukotrienes. Leukotrienes causes inflammation and also bronchoconstrictions in the airways. Hence, individual becomes aspirin sensitive when they have asthma.
Yeah, rightly said. Any more questions, guys? or anyone want to answer any query from the chat box? If fatinolol cross placenta, what are the adverse effects observed in fetus?
We can experience reduced heart rate and hypertension. And oligohydramnios is also observed, but it is not proven. Some rare cases, it has only like or 3 to 4 cases of oligohydramnios.
The adverse effects seen are like decreased heart rate, low sugar, and growth of the fetus is also slow down. So if you are using atenolol during pregnancy, then you should consult your healthcare provider about this.
Yeah, Nandhini, can you please explain what are the post-PTCA drugs that are given to the patient? Like after PTCA, while discharged, what are the drugs and class of drug that can be given to the patient?
First is antiplatelet agents like aspirin along with the clopidogrel or tecagrelor or a new agent like prasugrel. And next is in case of hypertension observed, beta blockers along with any other ACE inhibitors or ARB receptor blockers. After that, uh, in order to control hyperlipidemia, statins are commonly given.
Yes, perfectly answered. Anyone else want to ask any question, guys? Let's make it interactive, right?
Yeah.
Yes,
So,
Chaitanya is here. Come on, ask the questions.
so actually I'm not feeling well, but a little bit I will try. Okay. So we administered sublingual nitrates. So there is some specific nitrate-free interval. Anyone knows is what is nitrate-free interval? So what happens generally if we give nitrates more? If you suppose if patient has MI, you give sublingual nitrates. If patient is not resolved pain, again you give another tablet, or again you give another tablet, but pain doesn't relieve. So in post MI also, if suppose any ACS like unstable angina or nocturnal angina, so nitrate free interval. So in therapeutical practice, since nitrate free interval is uh, minimum 8 to 12 hours administration gap every day, because of the patient should give in the morning and afternoon, or in between 7 a.m. and noon, because of most of it will cover in transdermal patch also we can give mainly on for to prevent nocturnal angina, because of most of the angina sometimes we happened at nocturnal time only. And one thing specific point I read about in pharmacology is Monday morning sickness disease. So anyone know Monday morning disease? It's specific while I am reading in pharmacology. So what happens is Monday morning sick disease is there are some industrial workers in chemical factory. They are explosives with nitrates. So such they are manufactured in that particular company. So the workers develop certain symptoms like headache, dizziness, and postural weakness in several days. So, but what happens to the next after the week off and Sunday, the problem was solved. They didn't feel any such kind of symptoms. Then again come back to the work, they will have these all symptoms. So that's why they named as Monday morning sickness. So what pharmacology is in in this patient is, so generally uh, generally while we daily they exposed to the nitrates, they have nitrate intolerance. So in that condition, they feel uh, every day they exposed in the up to Friday they exposed in nitrates. They have some gap between Sunday and Friday. They don't feel any symptoms. After then come back to the Monday, they feel symptoms because of in 2 days they are on leave because they didn't experience of nitrates because of they don't expect nitrates because of they are in nitrate free interval. So this is the some interesting point that I learned from my pharmacology. So Monday morning sickness disease. So mainly the patient is or patient is working in explosive like nitrates. So in history, you can also check if the patient is worker as a chemical industry or anything, nitrate should not work for the patient. Okay, that's for my point.
Yeah, thank you, Chaitanya. If any more questions, please post in the chat box. Or anyone want to discuss anything regarding pharmacology of this MI? You are please welcome.
Hello, good evening, everyone.
Yes, Vaisakh, please.
I have a doubt regarding fibrinolytics. Uh, uh, Naturally, streptokinase are the drug most preferred in MI, but at which condition or at which relative absolute indication we should switch over from streptokinase to alteplase and tenecteplase? Because most often streptokinase are preferred in NSTEMI, and at which condition we should prefer other than streptokinase, other than the reason about other than allergic reasons, what are the indications we should prefer?
Okay, can anyone please discuss on this doubt of Vaisakh? Can anyone please answer?
Can you repeat once again, brother?
Sir, this is the question asked by my CR today. At which indication we should switch over from streptokinase to other fibrinolytic like alteplase, tenecteplase? Because most often streptokinase is the drug mostly preferred. And other than allergic reasons, what are the conditions or indication we should prefer other fibrinolytics?
Okay.
What are its relative and absolute indications?
Among the fibrinolytics, streptokinase is the cheapest. First. Okay. Hello.
Hello.
Yeah. Among the fibrinolytics, streptokinase is the cheapest form.
Okay, sir.
And we have already recombinant fibrinolytics is there, like tenecteplase, retiplase, artiplase.
Okay, sir.
These are very high cost. First thing.
Oh,
Okay.
okay, sir. Okay, sir. Other than cause, is there is any indication?
Yeah, if no more questions or doubts, guys, we have shared the link, post Q&A session link. You can answer the questions there, and also we'll be sharing the feedback form in some time so that you can fill up the form. In between, any doubts or anything, you can please post it in the chat box and start filling the form. We have five more minutes. Please fill the feedback form and also the post Q&A session form. Any more doubts to Nandhini actually? Nandhini presented really well, but no one asked questions today. Okay, if no more doubts and no more questions, let's wind up the session within 5 minutes. You people carry on with filling up the forms. I'll just give the vote of thanks for the session. I would like to thank all the interns who have been joined this session today. It was really very wonderful session, and thank you Nandhini for presenting. It was really insightful presentation by you, and I would like to thank everyone here, and thank you for Ajit sir and also CliMed and team for giving this opportunity and platform for all of us to contribute and also to show our skills. Thank you. Guys, you please fill the form so that we can end the session. Thank you, everyone.